All, this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. I was looking at various comments here and cracking up. So we'll continue with our long haulers discussion. The very first thing that I'm going to do today is present the medication or suggested medication by Dr. Afrin in his paper. Then we'll go over Dr. Afrin's paper and discuss why he thinks that long haulers is an MCAS issue or mast cell activation syndrome. After that, we'll talk about the diagnosis of MCAS and if there are ways to figure out that we may be vulnerable to become long haulers or to become severe COVID-19 from this perspective. Again, this whole theory is a theory. It is a conjecture. This is not yet finalized. Dr. Afrin and team has asked for clinical trials in this context. And finally, one more important news that what I have been seeing in various patients who are interacting with me or who are my patients have very, I actually don't have long haulers, but hey, Luffy, what's going on, Luffy? But what I'm seeing with the other patients or the patients who are sending me messages is that long hauling state is actually improving in almost all of them. It may take some time, but people are improving. So please keep your heart that you will actually come out of this situation. So with this, let's start. Okay, so this is Drbeen.com. I'm just going to go over a few of the links before. So this is a link to a study where they have discussed the postural orthostatic tachycardia syndrome, which is very closely related to the long hauling or the MCAS as well, and the MCAS syndrome. Give me 1 second. I want to open the door for Luffy. Okay. So in this one, what is interesting is to look at how they managed this person. And with her permission, they have her uncensored picture here. And they managed her with the low dose Naltraxone. So I wanted to make sure that you can look at this study as well. This is another study here, which is mast cell activation syndrome proposed diagnostic criteria. We don't really have a very good diagnostic criteria. And in case of COVID, it becomes even more difficult. And you would see that in the Dr. Afrin's paper as well. The reason for that is that in case of infections, mast cells are already working a little more than normal. Because of that, the lab criteria to see if the mast cells are working is generally true for everyone in case of COVID. So you cannot really say that this is MCAS or this is just normal mast cell behavior. We would still talk about some of the diagnostic criteria. This is one more little article where I think it is a little difficult to read, but there are proposed diagnostic criteria for mast cell activation, and it would be interesting to look at it. This is another link to the proposed mastocytosis and mast cell activation criteria. These are two separate things. Mastocytosis simply means increase in mast cell numbers, and mast cell activation syndrome means mast cells are incorrectly working more than they should be. And of course, there is a link to Dr. Afrin's study as well. I have that study over here, and I'm going to go over this with you. And I'm going to go in my own way of illustration. So the very first thing I would like to do is to add to the drugs, the suggested drugs by Dr. Afrin and his colleagues. And so what he's saying is, and I hope I'm pronouncing his name correctly. If he's listening or somebody, I apologize if pronunciation is not correct. The most important thing that he says is that please make sure that all COVID patients, regardless of MCAS situation, they are taking H1, H2 antagonist, histamine receptor blockers or histamine antagonist. The reason he says is that number one, it is safe. And number two, it will prevent anyone from developing the incorrect or unnecessary mast cell activation. In addition to that, he proposes that people should be given aspirin, famotidine, and we talked some of those yesterday as well, but I wanted to create a list of his suggestions separately. Famotidine, cromolyn. Cromolyn is something that he repeats again and again. Flavonoids, for example, quercetin is a flavonoid. Flavonoids are many times the chemicals that are derived from plants and vegetables. Leukotriene inhibitors, because leukotrienes are one of the substances that are released by mast cells. Janus kinase inhibitors. Janus kinase inhibitors are useful because when the mast cells are degranulating, that pathway for the mast cells degranulation action includes Janus kinase activity as well. So if you kind of block the Janus kinase, you kind of reduce the degranulation. Dexamethasone, and that is a steroid, and we know it is a steroid, and it has been useful for many other things as well. Of course, dexamethasone will suppress almost the whole immune system with inflammatory system. So of course, it would have effect on mast cells as well. Low dose naltraxone. So this is something that he said that it is important to try this. Quercetin and ascorbic acid. So if you see in our previous discussions, we have talked about aspirin, famotidine, flavonoids. We have talked about dexamethasone. We have talked about quercetin, ascorbic acid, and vitamin D as well. So many of these can be seen. Now with this, again, my hope is that those who have a long hauling syndrome or those who are managing the patients with long haul, they have right in the beginning an idea of how to start managing. Now let's look at the situation once more. So we know that this is the mast cell from our discussion yesterday. Important thing to keep in mind is that mast cell have various kind of receptors on them that allow these mast cells to see any infection present, any cell damage present, or viruses and pathogens present, and then they degranulate. And we talked about it yesterday, and we talked about the some of the mediators that are used by the mast cells to degranulate. There are hundreds of kind of mediators. We looked at some of them. Now I'm going to go specific to the information that is in the paper. So first of all, if you look at that paper here, I'm going to try not to read it, but just to keep you connected with this. So here they're saying that the mast cell activation syndrome is similar to that of a severe cases of the COVID-19. So let's look at it. They define MCAS as a chronic, that means longer lasting, multi-system disorder. That means it includes, for example, neurological areas, it includes GIT, it includes respiratory system, it can include other parts of the body as well. Because of that, many times it is the MCAS that a patient is suffering from, and we kind of think that they may have Lyme disease or some other chronic inflammation or infection, or they just simply, we say that they have some sort of chronic disease. And the authors say that many times they actually have MCAS. And they say it is very difficult for doctors to properly diagnose and then manage it. Now, one thing that we know about mast cells and their disorder are allergies. We know that a part of our society, a part of the people are allergic, normally about 20%. Authors have used the number 17%. 1/5 of our population can be allergic to those things that others are not allergic to. And this is why we call them allergen. Allergen's definition is something that only causes reaction in some people, while the majority of the population does not even react to those things. These things are called allergens. And it is not that that substance has a problem. It is that the mast cells react incorrectly to those things. And that is a mast cell activation issue. So allergies can actually be called as mast cell activation issue. Similarly, somebody had put a comment yesterday that, well, don't you think that if somebody is reacting to a vaccine that is not related to MCAS or mast cell? And the answer is yes, that is mast cell as well. It is mast cells that are reacting and causing anaphylaxis. So allergic reactions and inflammatory pathologies. So these are the I'm sorry, I'm distracted by Luffy. He was okay a few minutes ago. As soon as I started talking, he thinks that he needs to sing as well. Okay, so the second thing is prevalence. Mast cell activation syndrome is about 17% prevalent according to the authors. My textbook studies have been about 20%. So 17%, 20%. Now their conjecture, what are the authors saying? And this is a very important thing to understand from their paper. When I started reading their paper, I was confused about this one concept. So let me explain what I learned. My question in my mind was, are they hypothesizing that COVID causes mast cell activation and then mast cells stay active after COVID? One, or the SARS-CoV-2 sits somewhere in our body, continues to probe the mast cells, and the mast cell just keep going nuts. Two, or is this something else? So this is a very important concept that they have, at least in their hypothesis. They have said that it is not that the SARS-CoV-2 triggers MCAS, although they say it may be possible, but most of the time, it is that somebody is already allergic. They may or may not know it. For example, for majority of my life, I did not know that I was allergic to sulfa drugs. And only when I was 45 or so, and I had a surgery and they gave me sulfa drug and I developed a reaction, is when I knew that I was allergic to it. So many people actually do not know that they have allergies, but they do have allergies. And then when the SARS-CoV-2 arrives in their body as well, it kind of causes further triggering of the already allergic behavior of the mast cells. So they say that because of this, COVID severe occurs. So from their theory, severe COVID is also about 20% in the population. And we do not know why does it happen. And they say that, look, this is the same thing with the allergies as well. We do not know why allergies happen to some people. And that is the same problem with the COVID as well. So it is really not SARS-CoV-2 causing a severe disease. It is really an overwhelming response by the bad macrophages, mast cells, not bad, mutated mast cells. And they're responding overwhelmingly. Similarly, they're saying that just like people become allergic and they stay allergic for a long time, similarly, long COVID is nothing but a triggering of the mast cells, and they're behaving that way for a longer period of time. Good news is that what I have seen so far is that patients actually start recovering. Okay, so now, why are they saying that long COVID and severe COVID is actually because of mast cell activation syndrome? Here are the parallels that they have drawn. Number one, MCAS prevalence is about 17%, about 20%. Severe COVID prevalence is also 17 to 20%. Actually, it started with 20%. MCAS, or the mast cell activation syndrome, has an inflammatory pattern. So there are neurological symptoms, there are symptoms of allergic reactions, or there are symptoms of GIT issues. And they are very similar to the symptoms that appear in severe COVID and in long COVID. So they say they are actually very similar patterns. Then MCAS drugs. They are saying that the drugs that are used for MCAS, when given for long COVID or for severe COVID, they work as effectively as they work for MCAS, which means that under the hood, at the bottom of the whole structure, it is the mast cells that are inactive, or sorry, that are overactive. And so if you calm them down, they actually become, they leave the body alone. They have done one more interesting connection, and I had that question in my mind when I was reading their paper or this article. My understanding was that we have macrophage activation syndrome, or MAS, and all signs and symptoms and the labs of macrophage activation syndrome can actually be seen in patients who are severe. For example, hyperferritinemia, or ferritin levels are high. We know that, and that is actually a sign of macrophage activation syndrome. And here the authors had connected these two as well by saying that when mast cells are overactive, they can, in a secondary way, activate the macrophages as well. And so when macrophages become active, that is when the hyperferritinemia can occur. So they said that it is not a primary macrophage activation syndrome issue. The macrophage activation syndrome is a secondary issue to the MCAS. So that was interesting. And then finally, they say that we have been treating our patients. So they are suspecting that they are immunologists, and they've been treating their patients for MCAS. And they say all of our patients who have been treated for MCAS and have been taking drugs for MCAS, they did not become severe at all. So one more thing that is important in this discussion, they kind of looked at the severe and long COVID together. So this is a discussion for both of such outcomes. All right, so let's continue. So this is another important observation that they have in their paper. And they're saying that, hey, a couple of observations. Number one, they said, do you observe that some people become severe? And yes, we just talked about it. And they said their percentage is almost the same as the percentage of the people who have allergies. And secondly, they said, did you see that some people become long haulers as well, and their symptoms are very similar to the symptoms of mast cell activation syndrome? Now, if we just think about it, it is possible that this is a mast cell problem. And it is also possible that this is just not the mast cell problem. It is the SARS-CoV-2 and some other immune cell issue, which just keeps the whole immune system working more. And part of that is the mast cell working more as well. So it could be the mast cell causing it, or it could be that mast cells are just a participant of this whole phenomena, and we are just focused on them. Now, this is a very important thing. And I think that this discussion has been happening a lot. And that is it a hidden virus somewhere? And that is poking the immune system again and again? Or is it a problem with the immune system? And there have been some cool beans that have challenged me in the past as well, saying that how is it possible that you can have immune system not working correctly when there is no virus present anymore? And so I have discussed that in the past as well. It is called a phenomena of viral hit and run. So these authors have talked about that as well. And they said, look, it is possible that when the virus has arrived in our body, it has caused mutation of the stem cells. And those mutations then are present in the mast cell, and they are just dysregulated from then on. And not only this, they talked about, they also talked about it that generally mast cell incorrect activation is also because of incorrect mutations in them. So this is, I think, a very important takeaway, that they feel that these things are happening because of mutated abnormal mast cell activations. So we're going to continue to see the mechanism. So now the question is, if we go with authors and we say, all right, we understand that you are saying it is the mast cell activation that causes this whole thing. Tell us, how does this happen? So here is how they explain it. And this is the discussion, majority of this discussion here is the one that have been marked. This is what I have drawn there. I hope they don't mind that I've drawn it in a cartoony way, but let's look at it. So let's say here is a person whose mast cell is abnormal. So keep two types of people in mind. A person whose mast cell is not abnormal, and by abnormal what we mean is they have the mast cell has a mutation which is called KIT mutation. So there is a specific gene set that is mutated, which makes these mast cell a little bit more upset and angry about some of the substances for which other people's mast cells don't mind. So that is a mutation in them. This is called heterogeneity, or there are mast cells that have genes that are heterogeneous, or they're different from others. So imagine that we have a person here whose mast cells are already active abnormally more. So let's say this person has allergies. Then we come up with a stressor. In this case, the stressor being the SARS-CoV-2. And I think they have something over here. Somewhere here. So 1 second, let me just quickly find it for you so that here. So if you see here, primary MCAS has been thought by some to underlie to at least some extent many of the risk factors identified thus far for severe COVID-19 infection. MCAS is known to permanently escalate its baseline level of dysfunction of the affected mast cells shortly after a major stressor. So this is what we are studying right now. So here we have a cell. That cell was not working correctly already or was mutated. It was different. And then a stressor occurred, for example, SARS-CoV-2. That stressor caused normal immune response. And by normal, I mean it caused the immune system to respond. And in that response, immune system made a lot of cytokines, correct? Almost like a cytokine storm. When those cytokines occurred, there are two possible outcomes. So now imagine there are two people. One person already has allergies. They have a history of allergies. They have history of MCAS. That means their stem cell. So all these cells, the mast cells or the T cells or the B cells or neutrophils or macrophages or dendritic cells, they're all being made continuously in our bone marrow. And I have done this discussion in the past that when they're being made in the bone marrow, there are parent cells sitting in the bone marrow. These parent cells are called stem cells. These stem cells can become whatever cell they want, although they're not totiopotent. So for the medicos here and for the cool beans, we know this as well. Totiopotent means a stem cell that can become any of our body cell. That would be called a totiopotent, totally potent. It can do anything. Then we have pluripotent. Pluripotent cells can become multiple cells, but they cannot become all cells. So the cells that are in our bone marrows, they are stem cells. Stem cells definition is it is a cell that can make more of its own kind plus other kinds. The stem cell present in our bone marrow are pluripotent. They're not totiopotent. They cannot make brain cells, but they can make more blood cells. And within the blood category, blood and white blood cells, they can make various kinds of cell. That is why they're pluripotent, but they're stem cells. So imagine the parent cell for the mast cell has an abnormal mutation in it. And that is a KIT mutation, which is very commonly tested by immunologists to see if somebody has a mast cell activation issue. So let's say they have that mutation already present. The person is already allergic to various things. On top of that, now we are producing a lot of cytokines. The person became infected with SARS-CoV-2, and the immune system is making a lot of cytokines. Those cytokines are going to go into the bone marrow as well and ask the bone marrow to make more cells. And in that process, the stem cell that was sitting there, this is my depiction of a stem. The stem cell that was sitting there, that was already a little bit of mutated stem cell, is now going to become even more mutated. This is a key thing to learn from their paper. It is not that the virus has sat here. It is not that the virus is sitting somewhere sending messages to bother our immune system. It is the cytokines and the immune system's reaction and behavior that increases the duplication of new cells and production of new cells. In that process, there are mutations that occur. Whenever cells divide a lot, they mutate as well. Some mutations are harmless and some are harmful. Some are even cancerous. So when those mutations occur, they are hypothesizing that some mutations in these stem cells can cause further development of mast cells that are even more abnormal. So if I go here, if you see, this mast cell does not look like my original mutated mast cell, goofy mast cell. He is even more different. And why? Because it has accumulated more mutations in it. And now it is going to be behaving even more erratically. And that is what causes COVID severity or long haul. So if you see here, this guy is a little mutated. Now let's talk about someone who is not allergic, but still ends up triggering mast cell activation syndrome with this infection for the first time ever. How does that happen? That meaning this is a person who does not have history of allergies, but still ends up with the MCAS syndrome after the infection or due to the infection. So what happens is, so again, follow up with the same thing, that the stressor arrived in our body. Let's say that is a SARS-CoV-2. Immune system responded. Lots of cytokines are produced. Our stem cells in the bone marrow for mast cell are actually healthy and fine. So these are healthy and fine stem cells. They are just sitting there being dandy. And now they're being asked to make more of mast cells. So in that process, they also accumulated mutations for the first time. So they were okay before, but they did get mutated during this whole response to infection. And once again, now as they become mutated, they end up in the same state as this one. And from then on, when they make more mast cells, these are mutated mast cells. Now, these mutated mast cells would continue to cause issue now. So they used these terms in their paper: extreme mutational heterogeneity is what causes mast cell to continue to become more and more erratic. Okay, so moving on. They also then try to explain, not just try, they also explain why people keep getting the symptoms again and again, this cyclical fashion of, hey, I am having the symptoms today, then I became okay for a few days, then I started having the symptoms again. So why is that cyclical phenomena being observed? And what they're saying is that here is a mast cell that was erratic, abnormal. It keeps becoming flared up because of the normal immune system responses and because of other stresses of the body. And we know mast cells especially, as I was calling them moody yesterday, mast cells especially have a behavior of being erratic. Mechanical changes they don't like on the skin, for example, water, they would degranulate. Temperature changes, you go out from warm to cold, you can develop hives. You can dust, dander, so many types of allergens. So mast cells are very, very sensitive to responding to various things. So they are saying that those flare-ups of long COVID are actually just like mast cells allergies for other things. So for example, for a person who is in cold and is asthmatic, they keep developing the attacks of asthma in temperature variations. What is happening? The mast cells are flaring up every so often. So they're saying that when these mast cells that have become mutated by COVID, when they now continue to flare up, they would produce signs and symptoms, which the patient would say, it looks like I got the COVID signs and symptoms again. It's really the mast cells that are producing that behavior with their flare-ups. Then, so they use the word or words, MCAS flare-ups. Then they say, it is possible that these flare-ups and continuous cycling of the mast cell production and the new mast cell getting mutated and then they're flaring up and then new mast cell coming in, this whole thing can escalate to a point that the patient can develop neurological symptoms. How? Because there are mast cells present in the nervous system as well, and they can be degranulating there, causing inflammation. Fibrotic lung damage, they say, is very common because of the mast cell activation. So they are saying that those long haulers who have breathing issues even after are possibly because of the mast cells continuous activation. Other chronic outcome, for example, GIT issues or continuous cough or continuous malaise or myalgias, poor outcome from management. Similarly, when you as a doctor are managing the patient for COVID and the patient is still not responding because under the hood, it is the mast cells that are going mad and you are not responding to mast cells, you are figuring out everything else. So because of that, the outcome for management becomes poor as well because mast cells are not targeted. Or let me say it this way, the mast cells are also not targeted in addition to all other things that you're managing. GIT issues. So then we come to the point of how do we diagnose? And if I can very quickly once again show you this. In this paper, these extreme purple colors are where they have talked about diagnosis. So the basic outcome of this is the following. They say that, look, we can do blood and urine tests for mastocytosis and MCAS or mast cell activation. And the tests are tryptase level, and this is one of the most common tests for mast cell activation. Heparin level, histamine level, prostaglandins, then hyperferritinemia, looking at the, the other guy, macrophage activation syndrome. However, they say that it is really difficult to look at these higher levels and say it is mast cell activation problem because during the infection, these are active anyways. And so when they are active, they are going to be producing these things anyways. So just having high levels of these are not a diagnosis that a person has a chronic mast cell activation syndrome. The second thing they say is that there are diagnosis that is done based on PCR. For example, KIT mutations are analyzed. Codon 816 mutation can be seen. But normally, if that mutation is found, it is mostly for mastocytosis instead of MCAS. So they're trying to give you a lot of data to say, when you're trying to diagnose, here are the difficulties and challenges. Then they said we can do flow cytometry. So what happens is you put the cells in a tube, and as the cell is passing through the tube, you have a microscope and you are looking at the cell, and you are also looking at various markers on the cell, and you're then seeing what kind of a cell just passed under the microscope. This is like asking every human being to pass through a small channel, and you look from there and say, okay, man, woman, child, and so you keep seeing what kind of a person moved through the tube. So they say we can look for CD117, which is a sign of mast cell, with CD25 or CD2. But again, these are not the tests that are generally available in labs. But in extreme cases, these tests can be done. So this is the discussion that they have done. Here they've talked about this. At the end of the day, they continue to come back to say, look, this yellow thing here, MCAS targeted therapy, for example, inexpensive, safe histamine H1 and H2 receptor antagonist, immediately upon recognition or suspicion of onset of COVID, might mitigate the severity of illness. And then if you see here, I have put these in green, which are the things that they, so read this: aspirin, famotidine, then cromolyn, flavonoids, leukotriene inhibitors, Janus kinase inhibitors, dexamethasone, low-dose naltrexone, quercetin, ascorbic acid, and somewhere there was vitamin D as well. So that is the basic discussion. The takeaway for me was that once this needs proving now. Second, MCAS is an issue which normally doctors generally do not diagnose very well. For example, they've given an example that many times a patient is diagnosed as having irritable bowel syndrome or IBS, while in actuality, they have mast cell activation syndrome. And the doctors continue to treat them for IBS forever. Or a very common problem with continuous headache and GIT symptoms, not migraine, but headaches, GIT symptoms, respiratory symptoms, Sjogren's syndrome are actually underneath could be MCAS, while we keep trying to fix the patient's situation in other ways. So they're saying it is generally difficult. So the solution for them is very simple. That, yeah, we can get lost in the whole thing. The solution is simply give mast cell stabilizers and antihistamines throughout the management, regardless of your suspicion for MCAS or not. So that is what they're saying. And similarly, when you have a long hauling state, they are saying the same things, that try aspirin and famotidine and cromolyn and other naltrexone and so on. So this is the discussion. We will continue our discussion with the long haulers and other theories continuing in the coming days. Tomorrow we'll have Dr. Pierre Corey with us. I looked at the tweet in which I had asked for the questions, and there are tons of questions. I don't know if he'll be able to answer all of them or not, but tomorrow we'll have him. Then we'll continue back with the long haulers as well. So my question here to you, have you been a long hauler? Have you been taking some of these drugs, and what is your experience? And someone who was very upset with me yesterday that I called that I am not a fan of mast cell, and they were upset that why would I not be a fan of mast cells, and mast cells are great things. I realize everything is great, but there are sometimes mast cells that cause allergies and anaphylaxis. So out of all the cells, I have less fandom of the mast cells. So with this, let's stop. Let's continue tomorrow. I have a call. If you would like to do a little chit chat, we can do that, but probably for a shorter period of time. I have a call after this. But please do me a favor. Please like, subscribe, and share. There is a link in the description if you would like to buy me a coffee, or there is a link if you would like to be my patron, and there is a link if you would just like to support this work as well. And finally, please tell me, what did you think of Dr. Afrin's work, and what did you think of the conjecture and hypothesis that he have? So I'm going to come back online for another few minutes. We'll do a chit chat, and then we'll see each other tomorrow. Thank you very much. Bye-bye.